Welcome to your critical care RN cardiovascular pharmacology rapid review. In this video, I'm going to break down the must-know medications. We will start from the vasopressors to the inotropes or emergency antihypertensive. And if you're testing right now or preparing to test, these are your high-yield review that you need to watch to understand the drugs. I'm going to give you some tips and tricks how to remember them in the very short, rapid review. Let's get to it. The first thing we will do is to know the quick clinical tips. This is what you're going to use to answer some key questions. Always use vasopressin via a central line. It's a trap. Always, you have to know that. Don't pick a peripheral line when possible. If you have a choice, use a central line. Make sure the MAP, mean arterial blood pressure, is greater than 65 in a shock patient to maintain the goal. In cardiogenic shock, always keep the heart going. So ionotrope before you dilate to relieve pressure from the heart. You want to keep on pushing the heart. So use ionotrope before vasodilated. How do you know the endpoint of resuscitation? Is to check the lactate, urine output, mental status. That indicate endpoint of resuscitation. And the last thing too is titrate the medication based on the frequent hemodynamic reassessment. Don't just keep one rate for a long time. Keep on reassessing the patient and titrate the weight. These, when you know it, most questions you'll be able to answer it. Now let's get to those medications. So the first medication we're going to talk about is norepinephrine. That's Levophed. First thing you have to know, the class of medication. You have to know that. That will help you with the question. One, they are mostly alpha agonist than the beta 1 agonist. And how do they do that? They act on alpha 1 agonist to causes vasoconstriction. In the process, they improve your blood pressure. Therefore, their action will lead to increase in systemic vascular resistance, and that increase your blood pressure. If you have shock, if you have sepsis, and you have hypotension, number one medication you should use is the squeezer, and that is what? Norepinephrine, Levophed. During the process of squeezing, they divert blood away from organs that are not important, like your skin. So you can have peripheral ischemia, your blue toe, your toes turn blue. That is expected finding. Don't worry about it. But another thing you should know for is extravasation. If the IV leak into the skin, you can have necrosis. This is why we give it through central line to prevent extravasation as the fluid leak into the peripheral and it causes skin necrosis. The antidote is phentolamine, right? Key tips you're supposed to know: improve perfusion without greatly increasing heart rate. That's why it acts on one more than beta 1. So it will improve your perfusion more than increasing your heart rate. Number one, norepinephrine. Know this medication. Number two, dopamine is a good medication. It's an ionotrope, but it depends on the dosage. So your board will ask you questions based on your dosage. It's a catecholamine. It's like anything like norepinephrine. But how does it work? The dosage changes their function. A low dose, like 1 to 3 microgram per kilo per minute, is like a renal dose, we call it. It's mostly vasodilatory. It has on D1 receptors, and therefore we use it in kidney to improve kidney perfusion. So this low dose is not sepsis dose, but it's used to improve kidney function. A medium dose, that means 5 to 10 microgram per kilo per minute, is now ionotrope, is going to improve contractility, but the side effect is what? Tachycardia, because it starts acting on beta 1 receptors. When it's too high, greater than 10, it's now going to act on alpha 1. That is why it improves your concentrate and systemic vascular resistance, and it helps with your what? Blood pressure. So a low dose of dopamine or medium dose does not improve your blood pressure. They causes tachycardia, right? Or renal perfusion if it's 1 to 3. But if it's greater than 10, it's going to increase blood pressure because of vasoconstriction. What is it used for? Hypertension and bradycardia, because it's going to increase your heart rate and improve blood pressure. Because it can increase your heart rate, watch for tachyarrhythmia at higher doses. Okay. Next one, dobutamine is an inotrope, right? Inotrope means contractility of your heart, not vasoconstriction. So beta 1 more than beta 2 is a non-selective and beta agonist, right? Beta 1 or beta 2 is going to increase your contractility. It can also act on vasodilatory effect through beta 2. What do we use it for? Cardiogenic shock. So if your heart is not pumping, we got to pump for you. And so we're going to use inotrope, which is dobutamine. Also, if your heart rate, also if your cardiac output is low, this is what we use for. Also, if your cardiac output is low, this is what we're going to use to improve your contractility. Watch for it. Hypotension, because it's vasodilatory effects due to beta 2, and it can also cause tachycardia like dopamine. So all these medications know the class, know their action, what is useful and what you should watch for. And the key tips is don't use it as a solo pressor if the map is already low, because it's not going to improve it. You need to add it to something. So dobutamine and dopamine or something like that. Those are the key. Next question. Next keyword or next medication is nitroglycerin. Everybody know nitrate is a venodilator, act on the vein, right? It increases the capacitance of the vein. So it decreases your preload and keep all the blood in the vein. It doesn't go to your heart. But when you increase the dose, it becomes arterial venous dilation. So it can act both on the preload and the afterload. We use it mostly for preload in a heart failure. It can cause for hypotension and reflex tachycardia. Headache is the common side effect. You titrate it slowly. You, you titrate it slowly and it needs non-PVC tubing. That's the key aspect of that. Watch for that question. Nitroprusside is also nitrate, but it's more stronger than nitroglycerin because this one will act on both artery and vein at the same time. What does it do? Its action is going to decrease your resistance. So it decreases your blood pressure, it decreases the afterload and the preload, and it will improve your cardiac function. That's why we use it in hypertensive emergency and severe heart failure. One key issue is cyanide toxicity is very common if you use it more than 72 hours, and therefore you have to know the antidote for nitroprusside. Every nitrate are light sensitive, so you got to keep it in the dark area. You monitor for the evidence of toxicity, thiocyanide. Those are the key that will lead to cyanide toxicities. Therefore, this is how you have to have an antidote for thiocyanide. Amiodarone is an antiarrhythmic. What is this used for? To slow down the heart. If you have AFib, if you have VFib, tachycardia, and with rapid response, this medication we use. It slow down the conduction. It really change the heart to come down back to its baseline. What are the side effects? Number one, pulmonary fibrosis. The key word to know about amiodarone is P-clone. Pulmonary fibrosis is the key. P-clone means the P is pulmonary fibrosis. C, cardiac toxicity. L, it can lead to liver function elevation, right? O is uptake neuritis. N is neurological problem. And therefore D is what? Dermatitis. And E is evaluated. The problem with this medication is check for pulmonary function test, check for liver function test, and check for pulmonary function test. This is amiodarone, my favorite medication. Beta blockers, you know them. They have last name as law. They're blocking beta 1, beta 2 receptors. If it's a selective, it's going to act on your heart alone. If it's non-selective, it's going to act on your lung and your heart, and it can affect a patient who has asthma. What do you use for? To rate control, slow down your heart. When you have heart attack, you want to decrease oxygen demand of the heart. Beta blockers are very, very good. But if the patient has decompensated heart failure, don't use it. Or if they have a AV block, don't use it. Esmolol has very short half-life, so it's very good for titration. This is the best one. These are key buzzwords. If you know it, rapid fire, pharmacology, cardiovascular, you ace your test. ACE inhibitors is also my favorite. They have last name as PER, right? This is used in heart failure for remodeling. It's also used post-MI. It reduces ejection. If you have heart failure with reduced ejection, will help with the remodeling. Why does we use it for? It decreased afterload, it decreased preload, and improved the ability for the remodeling effect. Watch for cough. ACE inhibitor, A is angioedema, C is cough, E electrolyte problem, hyperkalemia, and I is teratogenic. So you have to watch it. These are key. If the renal function is abnormal, we hold it. And calcium channel blocker. They are all like, they act like a beta blockers. They slow things down. We can use it for any heart rate that is too fast, right? You can use it for hypertensive urgency. It also acts like a vasodilator. That's the same effect. So you have headache, you have flushing of your face, peripheral edema, bradycardia. Those are all signs and symptoms associated with what calcium channel blocker. And of course, avoid grapefruit juice. These are rapid fire pharmacology, cardiovascular for your critical care nursing. I hope you learned something, and trust me, if you watch this video multiple times, you will never miss a question. Take care of yourself and good luck. Bye.